Welcome everybody. Thank you so much for joining us. My name is Deepa Jayapalan and I'm the manager of the Healthy and Sustainable Food Systems team at Vic Health. It's my pleasure to moderate this event today. I would like to acknowledge and celebrate the First Nations people on whose lands Deakin University, Australian National University sit and where I'm dialing from today. I'd like to pay my respects to the elders of the Wadawurrung, Ngambri, Ngunnawal and Wurundjeri people, past, present and emerging, as well as First Nations people of all the lands on which we're joining from today. Indigenous women have been living, working, birthing, breastfeeding and successfully raising children for tens of thousands of years. Their skills and knowledges about feeding babies and children have been key to their health and survival. Colonial policies and practices imposed on Indigenous people during the last 200 years have disrupted the physical, sociocultural and spiritual environments related to birthing, including traditional breastfeeding practices. Our collective efforts can contribute to dismantling the oppressive systems that have resulted in negative health impacts for Indigenous people worldwide. Today, we are here for the Australasia Pacific launch of the 2023 Lancet Series on breastfeeding, which is freely available via the link that will come across on the next slide, and through the QR code as well, which you might see in a second. Hopefully the slide moves. This includes an infographic, which is an excellent, there you go, which is an excellent teaching resource, and an accompanying video of the launch event in London. This series has brought together thought leaders, thinkers and doers from across the region to discuss the important issue of protecting children, families and communities from the harmful tactics inflicted by the commercial milk formula industry. For thousands of years, the act of feeding between mother and child has been one of deep connection, love and nourishment, and foundational to life on earth. Yet this is being threatened by the commercial milk industry whose sole purpose is financial profit. The speakers today will uncover the exploitative marketing and lobbying activities of this industry, which preys on the insecurities of parents during a time of major transition in their lives. This contributes to less than 50% of babies being breastfed worldwide, as reported by the World Health Organization. A criticism of this industry is not a criticism of women or families or their choices. In contrast, the speakers today will discuss the multitude of societal structures and government policies that have facilitated the commercial milk industry to become the multi-billion-dollar powerhouse that it is, and the way they influence infant and young child feeding choices across society as a whole. The speakers today are concerned with the realization of the human rights of women and children to the best possible nutrition and health breastfeeding provides. Today, we're going to start with a short video from the London launch with opening remarks from Richard Horton, Editor-in-Chief of The Lancet. Then there'll be two presentations from two authors in the series, Julie Smith and Phil Baker, who'll present the findings of the Lancet series papers. We will then move into a panel discussion with Rosemary Stanton, Catherine Backholer, Penny Aora, Francis Katoni-Vuliku, and Libby Salmon, who have all worked towards meaningful transformation in this area. And then we'll hear from Roger Matheson, Director of Alive and Thrive East Asia Pacific. We'll provide reflections before opening up to a Q&A. As questions pop into your mind, please feel free to use the Q&A function on the Zoom chat. If you are tweeting about this event, please use the hashtag #ProtectBreastfeeding. We've also included the Twitter handles of speakers in the slides. Following today, the slides and video recording will be made available on the event website. Now over to Richard Horton, commenting from the series opening event in London.
With WHO in a project on accountability, and every time we took public evidence for women's and children's health, Patty was always there, encouraging, let me put it politely, like that, encouraging us to take this issue more seriously. It's taken us a decade, Patty, so I apologise that it's taken us a decade, but finally we're there. I'd like to just say how pleased I am to have worked with colleagues at the World Health Organization and CAP 2030 on this important series. A huge thank you to the authors, Nigel. I remember us sitting in a room at the Lancet pre-pandemic, and you were plotting this series, and you've navigated it brilliantly. So thank you to you and Dave and all of the colleagues who've made this possible. To the speakers today, to our wonderful panelists as well. In fact, the launch of this series on breastfeeding is actually a series of launches, not just one. We're in London today, but there's a launch for Southeast Asia tomorrow, a launch in South Africa on Friday, and in the Pacific region next Tuesday. I'd also like to thank all of my colleagues at the Lancet for their careful attention to the series, from peer review, the infographic that you'll see on our website, and the production, dissemination and promotion of this series, which is so important. It's not just about putting an issue on a shelf, it's about making it do some work. Now, I'm actually mildly anxious about making some brief opening remarks this morning, because I've already been attacked on Twitter because somebody very kindly said they can't wait to hear Richard Horton mansplaining about breastfeeding. So I'm not going to mansplain about breastfeeding. Instead, I'm going to confine my remarks to three fairly simple points to try and frame the series. The first point I'd like to make is a contextual issue. The near universal institutional commitment to and consensus around universal health coverage has been extremely welcome. For too long, we did not pay enough attention to how we strengthen health systems to deliver the alma mater goal of health for all, and universal health coverage is one means to do so. But the commitment to universal health coverage has, I'm afraid to say, come at a significant cost. Because in the Millennium Development Goal era, there was a laser-like attention and concern that was directed to women's and children's health. Remember, MDGs 4 and 5. And that was exemplified by the then UN Secretary-General Ban Ki-moon's signature health initiative, Every Woman, Every Child, which opened checkbooks from countries around the world and delivered many tens of extra billions of dollars for investment in women's and children's health. But since the end of the MDG era and the beginning of the SDG era and the focus on universal health coverage, I'm afraid to say that the spotlight on women's and children's health has dimmed. And that dimming is, to put it politely and diplomatically, more than regrettable. It's actually been a major setback for women's and children's health. Breastfeeding occupies a critical place in the health of the child and his or her mother. And so this series, to my mind, one additional purpose of this series, has a larger goal of drawing neglected attention to women's and children's health. A second observation, in the Lancet's 2020 Commission on a Future for the World's Children, and it's wonderful to see the leaders of several of the leaders of that commission here in the room today. It was actually chaired by Helen Clark and Awa Cole-Sek. They identified predatory commercial practices as increasingly threatening the future health of children in every country of the world. And the Commission identified the exposure of children and the threat they face to advertising from businesses whose products do harm the health and well-being of those children. The series we're publishing today takes that finding a step further, a big step further, by examining what is nothing less than the scandalous practice of commercial milk formula companies. What this series shows, in essence, is how the present and future health of our children is manifestly harmed by an exploitative industry that really represents the unacceptable face of capitalism today. The third point I will make, and this is where I stray into my anxiety-provoking territory, although I hope it doesn't cross the threshold of mansplaining, it does remain true today that still too many children are dying in the first month of life. UNICEF's most recent data that came out at the end of last year, beginning of this year, 2.3 million in 2021. That's over 6,000 newborns dying every single day. And early and exclusive breastfeeding up to 6 months has a very, very important part to play in reducing exposure among those children to contaminated food, pathogens in contaminated food, or untreated drinking water. So children in low and middle income country settings who are not breastfed have a much higher risk of morbidity and mortality from diarrhea and pneumonia. So all of us need to think about what more we can do to support women, to support families, to support communities in delivering safe and effective breastfeeding for children and mothers. That's all I want to say at the beginning. Thank you very much for coming today here in person and online. And so now let's dive into the detail. Thank you very much.
Thank you. So it's great to have Richard Horton set the scene of why the importance of this series. So our first speaker today is Dr. Phil Baker, an ARC Future Fellow at the Institute for Physical Activity and Nutrition at Deakin University. His research focuses on understanding global food systems change and the implications for human and planetary health. The current focus of his research is on healthy and sustainable first food systems, including the influences of commercial actors and forces on breastfeeding, complementary feeding, and food security for women, infant, and young children. He'll be presenting the findings from the first 2 papers in this series. Over to you, Phil.
Thanks so much, Deepa, and thank you so much also for moderating today's event. And thank you to everyone who has joined us from across Australia, New Zealand, and the Pacific region. It's hugely appreciated. I want to first acknowledge the authors of this series. This was an immense team effort spanning quite a number of years. 25 authors in total from 12 countries, and with huge thanks to the Lancet, the WHO, for their support for this work, and to Nigel Rollins, Dave McCoy, and Rafael Perez Escamilla for their incredible leadership in putting this series together. Infant feeding matters, and as part of that, breastfeeding is crucially important. In 2016, the first Lancet series on breastfeeding described why that is so. For those of you who may not be so familiar, breastfeeding has a very significant influence on human systems biology that has lifelong impacts on health and development. Now, this is true for infants in low, middle, and high-income countries alike. Breastfeeding also affects maternal health, reducing the risk of breast and ovarian cancer, and at a simple level, survival itself. The 2016 series estimated that if all children were actually breastfed according to WHO recommendations, then around 800,000 child deaths would be prevented every year. This series has come to be because of the observations by many that over the last 20 years, infant feeding practices have changed, and the recognition that globally fewer than half of infants are fed according to WHO recommendations. So it's a really important and long-standing global health challenge. 2 points on terminology. We use the term commercial milk formula in this series instead of the term that is often used, breast milk substitute. We do this firstly to highlight the artificial and ultra-processed nature of formula products, but also because the term substitute conveys the notion of equivalence. And the 2016 breastfeeding series and this 2023 series show how the evidence has strengthened and our understanding deepened about how breast milk is different from formula products and how it impacts on human health. Second, to clarify what we mean by the term marketing. We refer to any form of commercial communication or activity that's designed or has the effect of increasing recognition, appeal, consumption of particular products. And this includes advertising, but also distribution, promotion, lobbying, and sponsorship. It does not include the transportation or sale of the product. This is not about removing formula milk from the shelves of supermarkets or restricting access. This is about the marketing practices. There are four main messages that we distill in the series. The first is that breastfeeding success is a collective responsibility. It's not the sole responsibility of women and families. There are many externalities that constrain practices. If we want improved infant feeding, then we need both policy and societal responses to support women and families to breastfeed. The second message this series delivers is to take a deep dive into infant behaviors, like learning to walk or speak, sleeping and crying have normal trajectories, but these behavioral cues are easily misinterpreted or reframed by commercial marketing. The third thing is that formula milk marketing influences our beliefs, our values, our practices. It has negatively changed the infant feeding ecosystem in its entirety. The extent of influence and both the power of marketing and the power to market itself has not been fully appreciated by those in public health, civil society, and government circles. The fourth message is that there are many constraints on women who decide to breastfeed, and it's the ability of government to implement structural interventions and policies to both support breastfeeding and also to mitigate the negative undermining influences of corporate practices. So we come to the first paper in the series. Breastfeeding is crucially important, but increasingly challenged in a market-driven world. The paper starts with a conceptual framework that depicts the interactions ranging from the political and economic, and especially mother and infant relationships, and their impact on exclusive and continued breastfeeding. It documents how these interactions drive practices and what would be the policies and interventions that are needed to protect, promote, and support breastfeeding. Like any paper published in the Lancet, it is backed by robust methods, primary research, and very rigorous peer review. The primary research includes analyses of nationally representative surveys, systematic reviews, and case studies. So some insights from these papers, from the paper. The first message from paper one is about the late initiation of breastfeeding globally and the early introduction of pre-lacteal feeds. That is, giving liquids such as water or formula milks before breastfeeding starts. We see in the figure on the left, the blue horizontal bars represent the proportion of infants initiating breastfeeding within the first hour of life as recommended by WHO. Less than half of newborns are put to the breast within the first 60 minutes of life. These data come mainly from low and middle income countries because we don't have good data from high income countries. But if we did have good data from high income countries, these numbers would be even worse. On the right side, we see in all income settings, a clear correlation between giving any pre-lacteal feed and breastfeeding. Where you have higher rates of any pre-lacteal feeding, the top left-hand corner, you have low rates of early initiation of breastfeeding on the x-axis. And this is associated with shorter durations of breastfeeding and increased consumption of formula products. As I mentioned, paper one examines infant behaviors in a way other publications have not done yet. So the first thing to say is that human babies are born in an immature state. That's not a surprise to us, but they remain in that immature physiological and behavioral state for longer than just about any other primate. That means there is a significant process of post-birth maturation. So this takes time and actually support for young babies to learn to feed, to settle, and sleep. Sleep patterns of babies, as we all know, don't align with the patterns that we have as adults. Newborns express their discomfort through crying, and that signals the need for help and care. So crying is adaptive. It communicates many needs of the infant, not just hunger. The problem is that for parents who are tired and anxious themselves, it is a very difficult time to understand and read those cues well. In a systematic review of reports from 22 countries spanning different income levels among healthy young infants, normal behaviors like regurgitation or crying are common. At least 50% of infants posset or regurgitate. The average time that normal babies cry or that parents label them to be fussy is about 2 hours each day. Those are understandably distressing for parents, but they are not abnormal. And consistently, this undermines parental self-efficacy. And so it is no surprise that women report how their infants' behaviors shape their assessment of their own milk supply, and how crying, fussiness, poor sleep all undermine confidence. But it's not only mothers, it's also the partners, family members, health staff who misinterpret those cues. In these analyses, self-reported insufficient milk is the single most common reason given by 45% of mothers globally for first introducing formula milks in the first 6 months of life, and by a third of mothers for actually stopping breastfeeding itself. The irony is that the same evidence shows how effective counseling and support really does help parents understand these normal behaviors and improve breastfeeding. The flip side is seeing how what is considered normal being used as a marketing opportunity by the formula industry. New parents are legitimately concerned about those maturing baby behaviors, but maybe aren't understanding the cues. They just want to do the best thing by their baby. Yet we documented how marketing reframes these normal behaviors. The baby is crying too much, not sleeping because they're still hungry, and it presents these as abnormal, pathological, or that mothers are somehow inadequate. If you're not sure whether you have enough milk, then maybe your baby needs formula. If your infant has a rash or cries or is unsettled, maybe they have an allergy. So these inferences, these innuendos, are setting the stage to offer products as solutions for peace of mind or certainty. And without skilled support and reassurance, parents change from breastfeeding to formula milks, or from one formula to another. What we see and what we report in this paper in a series of case studies is that where countries make investments, they can improve exclusive breastfeeding rates, and they can do so remarkably. In Burkina Faso, Mexico, the Philippines, and the United States, we see a range of interventions. The creation of mothers' support groups, landscape analyses to inform policies, strong position statements from academics, extending paid maternity leave, using data effectively can all result in improved breastfeeding rates. This then takes us into an examination of the marketing of formula products. The title of paper 2 is provocative, a system to capture parents, community, science, and policy, but we believe this title is justified. The objective of this paper is essentially to describe the marketing playbook and its influence on people, on families, health professionals, and also the scientific and policy world. And again, multiple methods were included that you can read in the paper. And there are 3 main lessons that we convey in this paper. The first is that marketing practices are multifaceted. They are sophisticated and they are very well resourced. And because of that, they represent a powerful system of influence. It's not just a matter of some advertising here or a little bit of lobbying there. Together, these forces, these corporate practices come together to influence civil society, health professionals, and policy and regulatory environments. And this system is made even more influential through digital systems and marketing. The marketing playbook for formula is not actually all that different from what we see for other products, like training shoes, various other ultra-processed food products or drinks. What's different is that infant feeding has consequences for lifelong health and development, and marketing infringes on the rights of women, children, and families. They also represent a violation of the International Code of Marketing of breast milk substitutes. Formula milk is the only food product where the UN World Health Assembly, the world's member states, express their collective will and put it down on paper. The last main lesson is that marketing has worked. It has been very successful over decades, and it has reshaped individual, societal, and medical norms and values. As with paper 1, we started with a conceptual framework. And there's really only one point that I want to highlight here, and it's right in the middle, that everyone is a target of marketing strategies. Individuals, health professionals, governments, and politicians, we are all targets. We need to think about this problem from a systems perspective. And the objective is to shape our values and beliefs and to change our decisions. On the left, there are two figures. The bottom figure shows how sales per capita of all formula products are increasing. These are not just the total sales over time, the past 15 years, it's sales per capita, the kilograms sold per infant. All four categories of formula, standard, follow-on, growing up formulas, and specialized formulas are increasing. And that's why we can say that more infants than ever before are receiving these products globally. The top figure shows the relationship between breastfeeding rates and formula sales per capita, and the relationship is simple. Where you have higher sales of formula on the right of the x-axis, we see lower rates of breastfeeding at 12 months on the y-axis. In 2019, these data translate into annual sales of formula products to the tune of $55 billion. Sales were just $1.5 billion in 1978, a few years before the International Code of Marketing was adopted by the World Health Assembly. Now, there are many reasons for these changes, including preferences of families, work constraints of mothers, perceived insufficient milk, and poor support from health systems. But there is no doubt that marketing is a major influence as well. In our analysis of industry data, between 4 and 7% of annual sales are spent on marketing, and sometimes much more. That means for 2019, around $3.5 billion was spent by the industry on marketing, a figure that's equivalent to the annual budget of the World Health Organization itself. It's a figure that swamps, that drowns out spending on the promotion of breastfeeding by governments around the world. And we know that this estimate of industry expenditure on marketing is an underestimate because it does not include lobbying, social media, and sponsorship of health professionals. As I said, the title of this paper is provocative. Marketing aims to capture parents and communities. However, I will show you quotes from some of the 8,500 women across 8 countries who were interviewed about their experiences of marketing. Listen to their words and how they reflect marketing messages or suggestions. A mother in Mexico, all those scientific acronyms like DHA, you don't know what it is, but it sounds cool. It's supposed to be a nutrient that goes directly to the baby's brain. The mother in Vietnam who believed that if I want to promote brain development or height, then she would purchase a specific formula. Their beliefs have been captured. In South Africa, the mother liked the premium brand, the gold expensive look, conveying the sense of quality, or it was somehow unique. And for that product, she will pay a premium price. That's expenditure that is not going to vital other household goods and services like education, healthcare, and medicine. Her values were captured. The mother from London sharing how ads popped up out of nowhere, cookies being used by industry to identify when women are pregnant, and anchoring a strategy of targeted messaging, the process of capture and the technology behind it. And we see the same joined up strategy in packaging itself. These are just illustrative mock-ups of actual packaging. Industry invests in the science of communication and semiotics or ideas. Everything is deliberate. The colors use the little scientific emblems, the language of comfort, specially formulated for babies who are fussy, who have colic, or who are crying, appealing to aspirations and parents' values. Great start, the gold color for premium babies, the baby with glasses who's going to be smarter, quicker. And these messages and strategies are very deliberate. At a trade meeting in 2017, the CEO of one company said that infant nutrition wasn't necessarily about ingredients or innovation. What they were selling was sleep. Another panelist in the meeting said they were selling peace of mind, presumably to parents who had anxieties or specific hopes for their children. Health workers are an important target. In marketing terms, they would be referred to as category entry points. For those of you in the UK or maybe Europe, and even here in Australia and New Zealand, if I say George Clooney, you possibly would think of Nespresso. If you're in the United States and I say Michael Jordan or Serena Williams, maybe you think Nike. Health professionals are these same category entry points, mental triggers to purchase, because as we saw in the interviews of these 8,500 women, if a health worker recommends a formula product, then families are highly likely to follow that recommendation. Health workers are important because in all regions, they are cited by families as being key informants about infant feeding. But sponsorship of health professionals, sponsoring their research, their guidelines are means of influence, which most health professionals and associations believe they are somehow immune to, but constitute clear conflicts of interest. The figure of the echo chamber on the right is part of a stakeholder mapping undertaken in South Africa by a marketing company on behalf of a major formula producer. They position the scientific and academic community at the center of their echo chamber. And in the original, there were specific names of individuals because they know that if they can influence the scientific and academic leaders, then it influences their professional organizations, spreading to broader health communities and ultimately affecting consumer behavior. Lastly, in paper 2, we say that marketing captures policy and international recommendations. None of this is happening in a vacuum. International policy frameworks are being manipulated to decrease their effectiveness, and we see this in the systematic reviews, the case studies and analyses of public access information. The International Code of Marketing of Breast Milk Substitutes, agreed by the World Health Organization, by the World Health Assembly in 1981, in different ways, blocked, reinterpreted, circumvented, ignored by the industry. The Codex Alimentarius is another critical international regulatory body that has been established to protect consumer health. The evidence is clear how it is manipulated by industry to establish weak standards on formulas and other baby foods. In its marketing, industry capitalizes on the lack of implementation of maternity leave that protects breastfeeding. And we see the effects of lobby groups as they influence policy environments that shift things in favor of shareholder interests. To be clear, marketing itself is not inherently good or bad, nor are these conclusions that we make anti-profit. But what we have pieced together is a more complete picture of marketing than just advertising or occasional sponsorship of health workers. And we see the effects on policy, investment, and regulatory bodies. In particular, I want to highlight that a criticism of industry and its marketing is not a criticism of women and families, nor their decisions or circumstances, nor is it about trying to remove formula products from supermarkets. What we see is that industry deploys a system that is strategic, deliberate, very well resourced to turn the birth of an infant and the care of parents into a business opportunity. This undermines breastfeeding, it undermines human rights. That concludes my presentation, and now Julie, I'm going to pass over to her to give the perspectives and findings of the third paper. Julie, over to you.
I might just jump in, Phil, and introduce Julie. So our next speaker is Julie Smith, an Australian Research Council Future Fellow and Honorary Associate Professor at the National Centre for Epidemiology, Population Health at ANU. Her research focuses on gender analysis, taxation policy, and economic aspects of breastfeeding. She's been an expert advisor to government agencies and the World Health Organization, and to national and international NGOs. She's a co-founder of World Breastfeeding Trends Initiative Australia and an honorary member of the Australian Breastfeeding Association. Over to you, Julie.
Thanks, Deepa. Paper 3 is a political economy analysis that's organised using the framework in this slide. And at the top in grey, we have the tension between breastfeeding and commercial feeding and its direct impact on health and on social, economic and environmental outcomes that affect health indirectly. At the bottom, in the blue box, we have the political, economic, social and technological structures of society, including its institutions, its dominant ideas and beliefs, and the distribution of power and resources across society. So these are what are called the upstream or basic determinants. They are then linked to feeding practices and outcomes by looking at their influence in 3 domains of society, labelled in the yellow box. The first domain is commerce, where, having described the power of marketing in paper 2, we look at the industry's power to market. The second domain, care and work, focuses on gendered power systems and how society values breastfeeding. And the third domain looks at why health systems still fail to effectively promote, protect and support breastfeeding. Finally, and crucially, we look at the agency, mandates, interests and capabilities of different actors in both shaping and being shaped by the factors in the blue box, and their actions and policies and impacts across the three domains. So slide 3, as with papers 1 and 2, paper 3 draws on an extensive literature and on primary research that's been published elsewhere. So let's begin with the first domain. Phil has already described the staggering growth of sales of formula. What's also important to understand is that these markets are highly concentrated. Six companies control over 60% of the global market. Furthermore, formula is highly profitable, with research pointing to profit margins in excess of 20%. These features of the market are important because they underpin the enormous economic power of formula companies. Indeed, collectively, the 4 biggest companies generate revenues greater than the GDP of all but 60 countries globally, together own assets that are more than the private wealth held in every African country bar South Africa, and their workforce, which excludes the employees in their advertising companies, legal firms and professional lobby groups hired by the companies, is bigger than the combined health workforce of South Africa, Zimbabwe and Lesotho. Understanding the economic power of the industry is crucial, not just because it underpins its marketing power, but also because it underpins a powerful and sophisticated political strategy. This includes seemingly benevolent and public-facing corporate social responsibility activities aimed at purchasing social legitimacy and capital, as well as more covert action aimed at co-opting opponents and undermining implementation of the code. Much of this is carried out by extensive international and national lobbying networks that include a variety of industry-funded front groups, as well as the Food, Beverage and Grocery Manufacturers Association and the dairy industry. Efforts to curtail the regulation of marketing are also supported, especially in international trade forums and at the Codex Alimentarius Forum, by formula and dairy producing states, notably the United States, the European Union, Australia and New Zealand. And we also describe in paper 3 the commercial milk formula industry involvement in multi-industry and multi-sectoral alliances to further corporate interests in general. If the power, economic and political power of formula companies relative to governments, public health agencies and children and mothers is a problem, which it is, we have to understand how that power is accrued and consider how it may be curtailed. Globalisation and the integration of markets and supply chains is part of the story of transnational corporate growth, but is enhanced by neoliberal policy approaches that have privileged deregulation at the expense of public health, commodified and marketised more aspects of life, including the care of children, and expanded the power of financial capital and the drive to extract profits in ever more aggressive ways. International tax competition, avoidance and abuse, coupled with ineffective antitrust measures, have also shifted power and resources away from people, parliaments, regulatory bodies and public services towards transnational corporate and financial actors. Finally, formula companies are aided by the fact that the costs of not breastfeeding are externalised and paid for by others. This includes the health-associated costs we're familiar with in health systems and for families, but also the cost of considerable environmental damage from plastic bottles and formula packaging and the additional greenhouse gas emissions involved in milk production and the manufacture and transportation and use of infant formula. We also show how the increasing profits of the industry, the blue line in this graph, is accompanied by a trend of declining tax rates, the red line. Because much of these profits end up in high-income countries, while the harms disproportionately burden people in low and middle-income countries, the industry can also be characterised as neo-colonial and one that undermines sustainable development and worsens inequality. So let's move now to the second domain. Care work is central to human survival and flourishing and is mostly done by women. But it's ignored by mainstream economic accounting, despite the value of care work. Unpaid care work is estimated to be equivalent to 20 to 40% of GDP. This invisibility undermines breastfeeding and fosters a dependency on formula, while framing it as an individual lifestyle choice helps divest governments of their responsibilities for safeguarding the rights of children and women. So why is care work, including breastfeeding, excluded from economic statistics? The answer is that the international rules for measuring the economy, the UN system of national accounting, was developed in the 1950s by the UK and US, and the few countries that counted unpaid care work as productive activities then stopped doing so. Production is now only counted if there is a monetary exchange. Unfortunately, the SNA and its core component, GDP, gross domestic product, has become the main measure of economic performance. The system has long been criticised by feminists and environmentalists. Pioneer feminist economist Marilyn Waring famously called it a system of applied patriarchy. This key system has shaped social norms and beliefs about what is economically important, and its outdated and gender-biased ideas and measurement practices serve to perpetuate the invisibility and undervaluation of women's productivity. From 1993, GDP rules changed to include all commodities, including subsistence food production. This meant that all breast milk production should be counted in GDP. However, this has not been implemented. In 2009, the influential Stiglitz-Sen Commission reviewed how economic progress should be measured and concluded that mother's milk exemplified problems in how the system of national accounting measures material well-being. These two Nobel Prize-winning economists concluded that there is a serious omission in the valuation of home-produced goods, the value of breast milk. This is clearly within the system of the national accounts production boundary, it's quantitatively non-trivial, and also has important implications for public policy and maternal and child health. Statistics matter because they're the evidence on which policy is built and government budgets allocated. Economic statistics which exclude human milk wrongly imply that producing it is unimportant for the economy. When breastfeeding declines and formula sales rise, this is currently measured as GDP going up. This problem leads to further problems in terms of making a compelling investment case for actions. Money is the language of policymakers. Policies and investments in the food system will wrongly prioritise commercial baby food production, such as milk formulas for infants and toddlers. This is likely to have a lower rate of return to society than investing in breastfeeding. If the value of breast milk was more visible, greater funding priority might be given to programs which expand human milk production by increasing breastfeeding, such as implementing the Baby-Friendly Hospital Initiative and the 10 Steps and the International Code, financing access to peer counsellors or health professional lactation support, or to introducing better paid maternity leave and requiring breastfeeding accommodations in workplaces. To make this a reality, ANU, together with Alive and Thrive Southeast Asia Pacific, developed the downloadable Mother's Milk tool. The tool is user-friendly, and a downloadable version was launched in 2022 to mobilise early starters. It will go online in 2023. The Mother's Milk tool calculates that current production of human milk is only around 38% of its global production levels. So the lost milk is currently around 21.9 billion litres a year. The tool also calculates that 35.6 billion litres a year of milk is produced by the world's mothers, packaged sustainably and packaged along with nurturing care. The global monetary value of this breast milk production for infants and young children from 0 to 3 years old was US $3.6 trillion in 2020. The tool is useful for many purposes and by a variety of users. It's a logical counterpart to the cost of not breastfeeding tool, which has been developed by Alive and Thrive. It also complements the International Baby Food Action Network's WBCI costing tool for estimating the financing needs for breastfeeding, including maternity entitlements. The SNA economic measurement system depletes women through hiding the unequal sharing of overall work burdens. In effect, it treats unpaid work time as leisure. time use survey data from 64 countries show that women perform 3/4 of all unpaid care work. In China, women's average overall work time averages 7 to 11 hours more per week than men. Unpaid care work invisibly adds not only to women's overall work burdens, but also generates time poverty, stress levels, and reduces women's opportunities, including for recreation, leisure, and health. By not including unpaid care work, the SNA system is also misleading policymakers about economic growth trends. We can measure and value trends in this non-market activity with time use data and data on wages for paid work. When OECD statistics economists looked at this, they showed that GDP growth significantly overstated economic performance by as much as 1.8 percentage points a year in major countries in recent decades. This was because marketisation of economic activity over time was just replacing what was previously done by women without payment, like childcare. Reform to this flawed GDP measurement system is long overdue. The WHO Council for Health for All has called for reshaping and redirecting the economy, guided by new metrics, particularly rigorous time use data as an alternative to GDP. Time use data can support policy making in a number of ways, including by revealing largely hidden activities such as childcare and breastfeeding, and gender unequal leisure time. Gender budgeting uses such data to show what requires additional investments. Now, breastfeeding is a learned skill and takes effort as well as time, and those time pressures hinder or prevent optimal breastfeeding. Infant care is time consuming. In my Australian time use study of 156 new mothers, having a baby added between 40 to 48 extra unpaid work hours a week. Regardless of how the baby was fed, the mothers only got a few minutes a week help from fathers with care of the infant, although fathers may be helping with other children and with housework and so on. Lactating mothers interacted more with the infant. This responsive feeding and nurturing care is important for children to thrive. It takes time. Exclusive breastfeeding took around 18 hours a week, more than mixed feeding or not breastfeeding. All new mothers in the study had less sleep, more interrupted sleep, and less time for personal care, leisure, and recreation compared to adult norms, regardless of whether they breastfed or formula fed. Overburdened mothers are vulnerable to marketing. As paper 2 in the Lancet series shows, company marketing misconstrues normal infant behaviour and misleadingly sells sleep to exhausted mothers. We also know that industry was advised in 2014 in Australia that increasing paid maternity leave would reduce milk formula sales, and the opposite would be the case. This highlights that governments do not provide adequate maternity entitlements, and family members ignoring the housework are protecting CMF sales and harming breastfeeding. To breastfeed or CMF feed is not a real choice if breastfeeding means women and families must forego employment and secure livelihoods. Inadequate maternity rights protection and poor working conditions make it difficult or impossible for vast numbers of mothers to breastfeed. 82 countries do not meet any of the requirements of the ILO's Maternity Protection Convention, affecting hundreds of millions of potential mothers. The rising amount of work in the informal sector, or in sectors where work is precarious and underpaid, is disproportionately conducted by women. Low wages and excessive work hours generally may also affect how unpaid work burdens are distributed between men and women within households. Evidence shows that paid maternity leave increases breastfeeding. The ILO, the International Labour Organisation's research also shows that universal maternity protection, including paid maternity leave and breastfeeding breaks, paid breastfeeding breaks, is feasible and affordable in all countries, requiring investments of less than 1/4 of 1% of GDP. Finally, we come to the health sector, where we raise 3 interconnected issues. First, we highlight the problem of patriarchal and biomedical cultures that hinder culturally sensitive and woman-centred maternity care, that encourage intrusive and interventionist obstetric practices that undermine breastfeeding and contribute to the unacceptable lack of attention to breastfeeding in the core curriculum of health professional training. Second, we note the rise and normalisation of private-public partnerships and the increasing commercialisation and privatisation of health systems as trends that foster a more unquestioning acceptance of industry influence over health education, research and clinical guidelines, despite the clear conflicts of interest. And finally, we identify inadequate public budgets that leave health systems under-resourced as a major structural barrier to breastfeeding, and argue that greater amounts of public finance and investment can be generated responsibly and without causing economic instability, echoing conclusions made by the WHO's Council on the Economics of Health for All. So that's paper 3. As you've seen, we've covered a lot in this series. Each paper has its own set of recommendations, but I'll end by presenting 6 cross-cutting recommendations. First, parents, health professionals and society more generally must be given correct information about infant feeding, about infant behaviour and breastfeeding and the support needed to breastfeed. Second, there must be stricter regulation of marketing. Indeed, we call for an end to the commercial marketing of all food products for children, while strengthening implementation of the code. Third, we think that everyone should have a more complete understanding of the industry as a whole, including about the sophistication of its political and marketing strategies, and its broader social, economic, and environmental negative impacts. Fourth, we know that baby-friendly, women-centred and culturally appropriate maternity care will enable better breastfeeding. So proper investment in a trained and empowered workforce and stronger codes of conduct to eliminate conflicts of interest is a must. Fifth, it's unacceptable that so much of the work and responsibility for breastfeeding is left on the shoulders of women and mothers. The value of care work must be incorporated into economic accounting systems and policies. The unbalanced gender distribution of care work must be corrected, and investment in maternity protection and baby-friendly work environments must be prioritised. But finally, unless the imbalance in power between private actors with an interest in expanding formula consumption and those with a duty and mandate to protect the rights of children and mothers and women is corrected, little will change. Shifting power to correct this imbalance is ambitious and may be considered utopian. But by working across multiple policy areas and through broader, multidisciplinary, multi-sectoral coalitions, we believe it is possible. Thank you.
Thank you so much, Julie. And please don't forget, audience members, to please add your questions into the Q&A function. You can ask questions of Julie and Phil, and the panel that we're about to speak to will open up to Q&A shortly after the initial panel. We have a wonderful panel today, and please bear with me as I'll be reading through their amazing accomplishments. But I feel very lucky to have these esteemed panel members with us today. So firstly, we have Dr. Rosemary Stanton, OM. Rosemary is an independent public health nutritionist and senior visiting fellow at the University of New South Wales. She was awarded an Order of Australia in 1998 for her contributions to public health through nutrition. Her interest in breastfeeding started in the 1960s due to the tactics of companies marketing infant formula. She lobbied successfully for the first and every subsequent dietary guidelines for Australians to encourage, promote and support breastfeeding. With her current interest in sustainable food choices, Rosemary has even more reason to continue her campaigns for breastfeeding. So welcome, Rosemary. Next, we have Dr. Penny Aora, who's a research fellow at the Post Centre for Indigenous Health at University of Queensland. She's a maternity services and public health researcher and midwife, and until recently was embedded at the Waminda South Coast Women's Health and Welfare Aboriginal Corporation of the Yuin Nation. Her work has centred on maternal early years and primary care research and evaluation in diverse contexts, including in the Asia Pacific. Penny is a Ngati Pukenga woman from Aotearoa, New Zealand, committed to decolonising birthing for Indigenous women, communities and healthcare workers. Next, we have Professor Catherine Bacola, who is the co-director of the Global Centre for Preventive Health and Nutrition at Deakin University. Her work informs policy actions to promote health equity and to counter the commercial determinants of health. including the digital marketing of harmful commodities in Australia and worldwide. She's currently a member of the World Health Organization's Technical Advisory Group on the marketing of breast milk substitutes. Our next panel member is Dr. Frances Katuni-Vuliku, who is a health and nutrition specialist in the UNICEF Pacific Multi-Country Office of Suva, where she has been since 2016. Before joining UNICEF, she worked as a medical doctor for over 15 years, mainly in hospitals around Fiji, specializing in public health. Frances has also spent several years serving in the most remote maritime area in Fiji called the Lau Group, which is situated in the Southern Pacific Ocean. Lastly, we have Libby Salmon, who is a PhD candidate at the School of Regulation and Global Governance at Australian National University. She researches the regulation of women's food production for infants and young children through breastfeeding, including the contribution of human milk sharing to infant food security and health policy. Libby is a breastfeeding counsellor with the Australian Breastfeeding Association and the committee member of the World Breastfeeding Trends Initiative in Australia. So welcome everyone. It's great to have you all here. I will throw specific questions to each of you, but feel free to jump in if you want to add something. If someone has said something of interest, please feel free to jump in. We'd like to have a bit of a conversation going. My first question that I'd like to ask is to Rosemary. You've been at the forefront of working on breastfeeding and early life nutrition in Australia over decades. Can you offer reflections on how responses to this challenge have evolved and where are we now?
Well, thank you very much. Oh, I'm sorry, a bit croaky after sitting here for a little while. Yes, this did start in the 1960s for me, a great interest. It actually occurred after I had my first child in the 1960s. And at the time, we had a very enlightened boss at the New South Wales Department of Health, where I had previously worked, who thought it was crazy that I had to leave simply because I'd had a baby, and suggested that I run some prenatal classes, take the baby with me, and if the baby woke up, I could breastfeed him, which he thought would be excellent to see what was happening. After one of these lectures, standing in the corridor with a single mother who came to, or she was a potential mother, who came and asked my opinion about breastfeeding or bottle feeding, and I gave her my opinion, and this conversation was overheard and reported back to the health department, and I was chided because I should have known, apparently, that these prenatal classes were funded by a formula milk company. So this was a bit of a big problem and started me on my life as an activist favouring breastfeeding among other nutrition areas. I was very keen in the 1970s then to join in with the boycott of Nestle, which was introduced by the Baby Food Action Network. And I continued with that to this day, I might say. In 1981, when the WHO produced their code for formula feeding, this seemed to me that we'd been lobbying for a long while to have some Australian dietary guidelines. And so with intense lobbying, not only from me, but from a number of other dietitians and nutritionists, we wanted breastfeeding to be included in the first Australian dietary guidelines. And it turned out to be #1 guideline, promote breastfeeding. The problem has been that this was not popular with people selling the product. And so we found intense lobbying against having this as a dietary guideline. They're happy for us to tell mothers about it, but they didn't want it as a dietary guideline. And I was involved in the most well, they've been revised now, but the 2009 to 2013 revision of the guidelines, and we had intense lobbying. The guideline remains promote and support and encourage breastfeeding. So it's been a struggle, and it's been a struggle for a number of reasons. And Deepa, if I might just go into some of those reasons. When we did the last infant feeding guidelines, most of the formula milks were imported. And in the 1990s, I was appointed first by a Labor government, federal government, and then reappointed by a Liberal government for a short time anyway, to sit on the board of the Australian Dairy Corporation, and I was there as a watchdog. So I was to make sure that consumers were being represented and that nothing was happening within the Australian Dairy Corporation, as it was called in those days, that would embarrass the government. And to me, the greatest embarrassment would have been if Australia was promoting infant formula in third world countries, and that this, obviously there were some problems with that, and this might come back. So for those 6 years that I was on that board, we didn't do any promotion. It was fairly easy because most of the formula milks then were imported. So this became a bit of a problem. When my term on the board ended, so did the idea that we shouldn't be exporting or carrying on about the wonders of formula milks in other countries. If I go on to look at some of the problems that I see, we've had the problems that we now have a great range of products that infant formula companies are marketing. And these include things, so it's now a massive market. There are lots more companies than there used to be when I started out objecting to this whole promotion of these products. And then we had things like the toddler milks. Now, our infant feeding guidelines and our last dietary guidelines both specifically said that the toddler milks were not required. They were specifically listed as being inadvisable, and that children should, as far as possible, be having family foods when they started, and after 12 months of age, they could still be breastfed. But if they weren't breastfed, then they could have any other variety of milk. So as I see it, the tactics have got much worse, partly because there are so many manufacturers now wanting to have them, but specifically because we now have products that involve Australian dairy products. And whereas the Dairy Corporation didn't advertise that fact during the 1990s, they certainly do now. And we have lots of companies who are praised, and they're actually pushed to increase exports by the dairy industry, assisted by Austrade. And then we also find that the media gets on board with stories of individual companies and wonderful entrepreneurs who are now starting to market a variety of products with Australian milk from grass-fed cows or from goats. And there's a lot of problems with many of those with many of those products. They're sort of regarded as visionary marketers. And so we have far more intensive marketing of Australian products. So as an Australian, I find that deeply problematic. I could go on with some of my other problems with some of these things, if I may, just for a couple of minutes. And I have a problem with the Australian MAFE version of the WHO code that promotes marketing of infant formulas. It's hopeless. It relies on voluntary membership for a start, selective self-regulation, and the misleading advertising of a range of all those products that have similar names and labels. And this becomes a huge problem. So we now have a new government, and I think we need to change our method. We need to have a variety of groups lobbying for that current MAFE to be replaced with a stronger code, and certainly enforcement for all formula companies. When I see a complaint, when I see something that's nutritionally absurd, and I complain about it, and then I'm told, well, this company is not a MAFE company, so sorry, you can't do anything about it. I mean, how ridiculous is that? And so we have problems. I think we need to join with lots of people. So we need, obviously, midwives, and we need paediatricians, and we need the medical profession to join with dietitians and public health groups to ensure that the breastfeeding guideline remains in the current revision of the dietary guidelines, and to make sure that this MAFE code is replaced. So we certainly need better education, and we need social media connections with the public. But I'd say that the point where I think we may get some traction is if we had much more publicity linking the poor sustainability of products, which Julie has already mentioned. But these products use land and water, they increase greenhouse gases, and the packaging, of course, is a disaster, both in the making, the selling and the disposal. So it's all unnecessary. And I think we ought to be emphasising, as climate change and sustainability become much bigger factors for Australians, we should be emphasising the sustainability of the underused natural alternative that we could have of breastfeeding. So it's, to me, terrific that we now have so much information behind us in order to be able to lobby, because we've got so much ammunition from this Lancet series. So I just find it fantastic that instead of sitting looking for endless evidence, it's all there. So I think that all of us have this great opportunity and we should use it. Unfortunately, it means that I'll have to postpone my retirement, but so be it.
Yes, you can't retire anytime soon, Rosemary. There's still a lot more work to be done. Thank you so much for those incredible comments and for your reflections on how things have evolved, but also haven't evolved in a lot of ways, and the amount of work that we still need to do in this space. Thank you, Rosemary. My next question is to Penny Aura. Penny, if you're able to turn your camera on, that would be wonderful. In your work as a midwife and maternal health services researcher, what have been some impacts on families and communities of the commercial milk formula marketing that you've observed? And any reflections from your work, as you've had such a breadth of experience across various parts of this sector that we work in?
Yeah, kia ora, everybody, and thanks, Deepa, for that question, and thanks, Julie, Phil, and all the authors for an amazing paper, and all the series authors. First, may I acknowledge I'm on the lands of the Turrbal and Yagara people here in Brisbane, and I'd like to pay my respects to elders past, present, and emerging, and also extend respects to any First Nations people who are joining us today. I just would also preface my comments by saying they are personal observations, and I'm not speaking on behalf of any community, so I just want to make that clear. So yeah, the impacts, well, if you take a rights-based approach, the series highlights an important example within the broader area of birthing and maternity, in my view, where First Nations mums and families have and are routinely being denied the right to practice our traditional practices and knowledges. And these are embodied knowledges that have, survived for thousands of years. Breastfeeding is a practice, a knowledge, and it's a fundamental right. And these are protected under the UN Declaration of the Rights of Indigenous Peoples. But as has been mentioned, the aggressive and targeted marketing has meant that First Nations families are being denied the health and wellbeing benefits of breastfeeding and being breastfed. And this is happening in many ways, as explained in the paper, and is another contributor to the burden of illness faced by many First Nations families. It's another example indicating how birthing sovereignty has been taken, but that's changing. I really want to draw attention to the work of many of my colleagues, friends, sisters. First Nations women everywhere are demanding sovereignty over our bodies and our births, and communities are taking back what was taken and reinstating the important relationships around birthing care and birthing practice, and those that support optimal birthing outcomes, including breastfeeding. So there's a change happening here. Yeah, there's a lot of misinformation out there, and getting the right messages and information and the essential support is important. We know that enabling environments are important and that they're needed, and that's where there is good evidence that's shown, again, pointing to the work of my colleagues. And it's what we already knew as First Nations women, that women need the right support from the right people. So peers, elders, First Nations health care providers, including family support workers and other support workers, these are making a difference. And where such support and care is available, First Nations-led initiatives like Birthing on Country, Birthing in Our Community that we have here, they make a real difference and families get the best start. Does that answer your question?
Of course it does. Thank you so much, Penny. That was wonderful. And I'll come back to you because I have more questions to ask you. But I might go first to Catherine. Hi, Catherine. So marketing of these products used to be seen on TV and billboards, but as we increasingly live in a digital world, we are bombarded with ads from formula companies online. Just how powerful is this digital marketing, and what most concerns you about the way they're operating in this online world?
I mean, I'll start with what concerns me, and I think it's, you know, what the series highlights really well, and that's the unethical nature of, you know, marketing more broadly that was covered in the series. In terms of digital, so marketing is a function of exposure, so how much you see of that marketing message, and then the power of that message, so how much you engage with that message. And the digital marketing through digital devices or online platforms is amplified both in terms of exposure and power, making the whole digital marketing much more impactful. So I'll walk you through that. So in terms of exposure, digital marketing is much more, you know, has much greater exposure because of the huge numbers of the population that spend time online. We know that there's an ability for marketing messages to really spread virally through the internet, reaching large numbers of people. And really importantly, which the series highlighted really well, was this hyper targeting of marketing messages through the harvesting of personal data, which is then really combined together to create these lookalike profiles and then commodified by selling it to third parties like the commercial milk formula industry, so that they can precisely target the right person at the right time to buy their products. And I'll also say that more and more advertising, especially online, comes with a buy now button. So there's this seamless transition from a marketing message right all the way through to a retail outlet and a purchase and distribution. In terms of power, we know that marketing messages are algorithmically and automatically personalized. So for the same marketing campaign, what you see and what I see can be completely different, and that's automatically generated through algorithms. And marketing messages are not static anymore. So they have this immersive content to pull you in so that you can engage with it. And I think really importantly here, you know, this is often women, whether, you know, before pregnancy or, you know, when they're in those early, you know, really tiring days of having a newborn, they're receiving these messages through trusted sources. So it's their friends, their family, their mothers groups, or influencers as well. And this is how the information is being shared, usually generated by a commercial milk formula industry that pays for that marketing message to get out there. It's then shared amongst peers and influencers, and then also algorithmically boosted through paid ways to make sure that it comes to the top of people's pages. So I guess that's why digital marketing, I think, is really important. It's not explicitly, you know, the nuances of digital marketing are not explicitly written into the code at the moment. And I think that needs to be, you know, strengthened. And I really like the call within the series around a convention to, you know, take that one step further as well.
Thank you, Catherine. My next question is for Frances. Frances, through your work with UNICEF, you've reported that women and babies in Pacific Island countries have enjoyed high rates of breastfeeding in the past. Though alarmingly, breastfeeding is declining and formula use is on the rise. Can you say more about what you've observed in the Pacific countries, and why do you think we are seeing these changes? Over to you, Frances.
Thank you. Yes, so the recent mixed survey for the Pacific Island countries, it does reveal that the proportion of children receiving breast milk within an hour of birth, as well as exclusive breastfeeding for the first 6 months, are indeed dropping. And one of the attributes to this is that most of the Pacific Island countries, they have few legal measures in place to protect mothers from misleading information that is being widely circulated, and also the lack of policies to protect them from the impact of or the persuasive power of advertising and the promotion of breast milk substitutes. But at a more community level, we see that more women are now finding suitable paid jobs to support their families. However, the availability of a safe space in the work area to support working mothers breastfeed, this continues to be a challenge. And also at the homes, we are observing that mothers are not as supported as we would like. And so this kind of leads to the lack of will to continue breastfeeding, and also the absence of the support groups that we used to have in the past. For example, like the peer support groups or the women's group, or the faith-based organization where we have support groups to support women to continue to breastfeeding. We don't see that as much as before. And also breastfeeding now, it's looked upon as an old-fashioned trend, and young mothers, they tend to be influenced by their peers or opt for breast milk substitutes as the society feels that is trendy. And although these may seem like simple issues to solve, but it's very challenging, and we from UNICEF will continue to support breastfeeding and working with countries and communities to support breastfeeding in the homes as well as in the communities that they live in. Thank you.
Thanks, Frances. I might even just pick up on that point that you just mentioned, as that was the thing I was going to ask you about anyway. So what is UNICEF actually doing in this work? It'd be great to hear more about what you're doing on the ground.
So UNICEF is continuing to support countries to firstly have strong legislations to protect the families from the false claims about the safety and the role of breast milk substitute or aggressive marketing practices that are in place. UNICEF is also working closely with the Ministries of Health to strengthen primary health care and support breastfeeding programs, as well as strengthen the capacity of health workers in counseling and supporting breastfeeding at a primary health care level where they're closer to the homes and do more home visits and be more engaged with the communities in that sense to really support breastfeeding and scale up breastfeeding at the community level. We're also supporting ministries of health to leverage on existing services like we have immunization, antenatal, postnatal care, and integrated management of childhood illnesses program, and provide infant young child feeding counseling during all these contacts with the mothers and caregivers so that we don't miss an opportunity, but we take every opportunity that we are engaging with the mothers and caregivers and really advocate for breastfeeding. UNICEF is also working closely with the Ministries of Health to engage with communities and to clear any misconceptions about breastfeeding, as well as empower these mothers and caregivers to make informed decisions on breastfeeding. Now, these are some of the support that UNICEF will be working with countries and more to support breastfeeding. Thank you.
Thank you so much, Frances. And my next question is to Libby. Libby, in your research, you write about the critical importance of breastfeeding to infant and young child food security. Can you say more about this and how it intersects with the findings of the series papers?
Hi, everyone, and thank you for the opportunity to join you today for this discussion. And I'm speaking from Ngunnawal country here in the ACT. Although not addressed at length in the Lancet series, food security for infants and young children is a key issue, and this is reinforced by events such as the floods in New Zealand and Australia, the formula crisis in the USA 2022, and of course the terrible earthquakes in Turkey and Syria. So the connections between infant feeding and food security occur through globalisation, international trade in commercial milk formula, and the stresses on the dairy sector, supply chains, concentration of corporate ownership, and the risks of climate change. They all come together in this nexus around security. And Australia's role as a bad policy actor embeds this vulnerability. So I believe that framing breastfeeding as a first food security issue, a term coined by Phil Baker, offers a counter-narrative to some of the marketing of formula as a solution, as described in the second paper. So recognising breastfeeding as a food security issue provides an opportunity to position breastfeeding as building resilience to natural disasters, economic and political crises, and to climate change. And it also is important in refocusing attention to the everyday food insecurity in households that are not supported to breastfeed for all the structural reasons described in the Lancet series. And so resistance to framing breastfeeding as a food security issue is to be expected, and a really recent example is the current Australian parliamentary inquiry into food security, which is just starting public hearings, has stated that breastfeeding does not fall within the parameters of the inquiry, and it's rejected our submission by breastfeeding experts. And perhaps, given the Lancet series, this rejection is not surprising. The inquiry is being run by a standing committee on agriculture, and our submission outlined the interference by agricultural and industry interests in breastfeeding policy in Australia and internationally, including in neighbouring countries for markets for formula products. The Lancet series is incredibly valuable to strengthen evidence of this interference. So our submission has been referred back to a health committee away from this trade framework, and it's very important that we stop policymakers from maintaining the fiction that breastfeeding and health are divorced food systems. So I think the first food security framework provides an opportunity to perhaps contribute to the Lancet 6 key recommendations in paper 3. The series really shows the importance of framing and coalition building to counter commercial power. So there's potential food security to shift the narrative around infant formula as a solution and reveal it as a vulnerability. This reframing may shift industry's discursive power and the norms and beliefs held by the public and policymakers. So disasters and supply chain crises are great levelers. They're terrible levelers, exposing our shared human vulnerability. They expose the powerful to the risks the poorest in our communities and regions suffer on a daily basis, especially those in regional and remote areas. Crises reveal inequities and blow apart the myth of choice in infant feeding. So there are many other ways I think that this framework contributes, and I think it's worth further investigation, and I certainly really welcome the Lancet series on putting all together such an excellent body of evidence to inspire this work.
Thank you so much, Libby. And you will all get more of a chance to ask these panel members more questions. We're seeing some great questions come through in the Q&A as well. So next up, I'm going to pass over to Roger Matheson, who will offer a response to the series findings. Roger is the director of Alive and Thrive in the East Asia Pacific, and who leads FHI Solutions Innovation Incubator. Roger is a clinical nutritionist, researcher, and public health manager with over 2 decades of experience working in civil society organizations, the UN, academia, and the private sector. Before joining Alive and Thrive, Roger worked as a nutrition specialist for UNICEF and provided technical capacity and emergency support to countries in Africa and Asia. Roger is joining us from Vietnam, so I'll pass over to you now.
Thank you. So yeah, thank you for this opportunity to reflect on the Lancet Breastfeeding series presented so well today by Julie and Phil, and also respond to some of the points made by the panelists. Just looking through the participant list, so it's wonderful to see that we have so many familiar names from the region, also advocates calling in from beyond the region, including the US and from Japan. So that, I think that's 2 other countries that are often in opposition to the work we do to protect breastfeeding in the region, in East Asia and the Pacific. So it's important that we have this knowledge exchange across the regions. Yeah, so back to the presentations. Around the world and for generations, the contributions of women have too often gone unrecognized and unvalued. And today, the presentations by the co-authors really explored further how mothers and breastfeeding are still undervalued and underinvested in by governments and public health. So that brings me to 2 important points. And the first one is what's measured matters. And the second one is to echo what Julie said in her presentation, that money is the language of policymakers. And an important point here is that countries have used GDP to measure economic output, using the economic value of various activities, and use that to guide policy making. But for every country except one, except for Norway, the value of breastfeeding has never been considered. But there is hope now, with some countries progressing towards a well-being economy, and also with the release of the mother's milk tool that Julie mentioned. So we're finally taking some important step towards addressing some of these serious omissions. A key message also to policymakers from the Lancet series and the mother's milk tool is the global monetary value of breastfeeding. That was estimated to be 3.6 trillion in 2020. So that's 3.6 trillion with a T. And the tool also comes with a new policy ask, in addition to what we may be more familiar with as advocates, and what is recommended by the Global Breastfeeding Collective. And the new ask is to count breastfeeding and mother's milk production in national food balance sheets, food statistics, and food surveillance systems. So that requires us to focus on, even more on the food system, and collaborate also with the systems for national accounts. I don't think many of us have a lot of experience working with the systems for national accounts. Yeah, one of the biggest investments to enable recommended breastfeeding practice is enacting adequate maternity leave and maternity protection. We talked a lot about formula marketing, but I think we also need to talk about maternity protection. And what is felt as adequate maternity protection by mothers might be very different from the current minimum recommendations from the International Labour Organization. We need to remember that that is a tripartite UN agency with government, employer, and worker representatives. There is also a growing consensus that at least 6 to 8 months paid maternity leave is needed for women that works both in the formal and the informal sector. So it's important to align this period of paid maternity leave with the recommended exclusive breastfeeding duration, as it requires mothers and babies to be close together. Furthermore, it's not only paid maternity leave that is important. You have also other maternity protection provisions, including workplace policies, and they need to be in place to support continued breastfeeding for 2 years or as long as the mother wants when they return to work. At least in the countries I work, most of the regulations have kind of limited that up to 1 year, but there's kind of no reason why it should be like that. And policymakers also need to know about the tremendous human and financial cost of not breastfeeding when you look at the investments needed for maternity protection. So it's a small investment that is needed compared to the tremendous cost of not breastfeeding. You have maybe noticed that I use the term maternity protection and maternity leave, and I do that deliberate. Breastfeeding needs to be better recognized as reproductive work that should not be reduced, and it cannot necessarily be redistributed as part of policy solutions to get mothers back in business and as taxpayers before they are ready, or other gender equity agendas that doesn't consider protection of motherhood. Motherhood is actually protected, and that's stated in the Universal Declaration of Human Rights. So rather the agenda involving the 3 R's of reducing, redistributing, and recognizing time for work, for care work, needs to be reconceptualized to isolate breastfeeding as sexed care work. And we think with this reconceptualization, economic adjustments are needed to also appropriately recognize and reimburse for the value of this work. So touching a bit back on what Julie was mentioning in her presentation, but we're also more on this will come soon. And a team of global experts are currently working on this, including Carleen Gribble from the region and Julie Smith. Yeah, and the second point, big point with the Lancet series is exploitative marketing. And the Lancet series highlights the vulnerabilities of women and families that are exploited by the commercial milk formula industry. We know that this is a multi-billion-dollar industry. They have considerable economic power, and they use a marketing playbook that includes political lobbying and interference with international regulatory processes. And I just want to go back to the actual papers and cite some really concerning research findings. Between 1995 and 2019, there were 245 interventions made in the World Trade Organization by commercial milk formula and dairy producing member states. And these interventions were concerning the regulation of formal milk marketing, labeling, or safety in another member state. So interfering with another member state. Australia and New Zealand are among these interfering member states. And they have weakened other countries' breastfeeding protection laws. I think we just really need to pause and think about that. And what kind of policy actor you are when you interfere with other countries' processes. And yeah, talking about the lobby, Rosemary Stanton gave us a useful history lesson, including the intense lobbying for the infant feeding guidelines and her role as a watchdog in this process. And I think it's important to learn from the past and make this inform the way forward also for Australia, but beyond. And especially since tactics have gone much worse and with the media, and if I heard correct, even Australia involved. Related to this, a call for Australia to put babies before bottom lines and to end exploitative marketing of commercial milk formula both at home and abroad was recently published in the Lancet Regional Health for Western Pacific. And in this commentary, we also highlighted that instead of binding legal measures, Australia has adopted a voluntary system, an agreement of industry self-regulation among signatory companies. So not surprisingly, this is among the weakest measures globally. However, there is a process going on. In 2021, the Australian Competition and Consumer Commission considered the reauthorization of the agreement and prior to the decision, welcomed submissions from stakeholders. And the Commission received local and international submissions, including from civil society in Myanmar and from Cambodia. And they provided evidence, contrary to the claims by the commercial milk formula lobby, that agreement contributes to public benefit. And these submissions also called for Australia to adopt binding national legal measures on the code. And they also note a wide range of international exploitative marketing activities by the Australian companies. And some of these examples are really bad. It includes Australian diplomats pushing formula and milking it for the formula companies. Especially, it's not only Australian, also seeing New Zealand diplomats in action. And you know, they have immunity. So they are actually pushing something that is illegal in another country, and they have immunity, so no consequences for them. But also mentioned was promotion of commercial milk formula products within healthcare systems, celebrity endorsement, and misleading and inaccurate health claims. So the Commission in Australia, they did reauthorize the self-regulatory non-binding standards, the one that was not effective. But they also mentioned that it's actually the responsibility of the Department of Health in Australia, to follow up on the code. And it has been over 40 years since the World Health Assembly, including Australia, ratified the code. So as we stated in our commentary, it is time for Australia to correct this historical inaction and to make this a reality. Past and present policymakers needs to be held accountable. This has been on the to-do list for the Minister of Health in Australia for over 40 years, but nothing happened. So why? In other countries, media also plays an important role in this. And I'm a bit surprised that most of the media coverage, at least the one I have read, related to breastfeeding in Australia, is featuring advocates, but not interviewing or challenging the people in power, including past and present Minister of Health, Ministers of Finance. Where's the resources for your strategy for maternity leave and so on? What about the Minister of Trade? We have questions for the Minister of Trade, and we have questions for the Ministers of Foreign Affairs, and why we have such behaviors of your diplomats abroad, among other things, and how you act in international fora. So you also, I would like to say to the governments that you have a tremendous resource in the academia and civil society organizations that you really should tap more into. So maybe find new friends in them. I think that would be best for breastfeeding. Penny Haura highlighted also right-based approaches and the right support needed around birthing, and with focus on First Nations women. And as part of this, it is important to also ensure that this support is free from any conflict of interest. So leading up to the Lancet series, we also published a commentary on conflict of interest in BMJ Global Health. It was an additional study related to the overall 40-year scoping review that we had done on evidence of code violations that was also referenced by the Lancets. So just want to mention one key point that in that commentary, and that is that the national regulatory measures to implement and also ensure monitoring of compliance with international code, it also protects health workers and not only children and their families. So we need to work on regulating institutional kind of conflict of interest and have those policies in place. Yeah, so Dr. Catherine Backholler reminded us about the massive digital transformation we are currently experiencing, and also making marketing more personalized and tailored through algorithms. And digitalization is a mega trend identified both as a threat, but it can also be an opportunity for us. And in Vietnam, we have an innovation now called Vivid, which was born out, it actually means virtual violations detector, and is a virtual assistant, and it has been trained to scan and flag code violations, and it is now replicated to some other English-speaking countries, and it's been integrated into the corporate accountability tool and communication hub. So if you want to learn more about that, you can go to corporateaccountabilitytool.org, and you can actually see on a daily basis all the violations, including from Australia and New Zealand. We did include that for a period of time, so you can help inform your policy development. And we're also looking forward to work more with Catherine and the team and her team to document this innovation, and hopefully we can expand it worldwide. So I would like to end by recognizing that this event includes countries and territories in the Pacific, and Dr. Francis provided a great overview on breastfeeding programming. And the main concern right now for Pacific is probably climate change and mitigation efforts to literally keep head above water. And the negative environmental impact associated with the commercial formula milk industry, the food industry, but especially the commercial milk formula industry, it is substantial. So as mentioned in the Lancet series, these include water use, pollution, packaging waste, but also greenhouse gas emissions. In 2018, 2 million tons of commercial milk formula was sold globally, and this would mean between 14 and 28 million tons of greenhouse gas emissions and 10 million cubic meters of water. These are big numbers. But through innovations such as the green feeding tool coming soon, we have the potential to positively influence the design of policies and programs across food and health systems to reduce greenhouse gas emissions and climate-related impacts. So this quantification tool under development puts the power of data in the hands of policymakers, in the hands of advocates, and climate change scientists, and it enables them to evaluate the reduction in greenhouse gas emissions and water use by increased breastfeeding and reducing the reliance of commercial milk formula. So while providing a tool to aid governments and stakeholders to mitigate climate impacts, the green feeding tool also supports advance in global breastfeeding rates in line with the World Health Organization targets. So the aim is for this tool to be available by the International Environmental Day in June this year. I hope we manage. So please do not retire, Rosemary. We have a tool for you soon to capture your recommendations to focus on carbon footprint of commercial milk formula in our advocacy. So thank you for your attention.
Thank you so much, Roger. That's wonderful. We're now going to spend the next 15 minutes with the open Q&A. We've seen some great questions coming through. So I'm just going to ask all of our panel members to put their cameras on so we can easily have a conversation between each other. Also, I'm not sure who's in charge of spotlighting, as that might also be contributing to us not seeing everyone on the screen. So I can only see Roger's view on my view, but that might just be me. Okay.
Yeah, we can see. We can see.
You can see everyone? Okay, great. And we might just need the Phil perhaps stop sharing so then we can see everyone's videos instead. Okay. So the first question that I'm going to throw there, and I'm going to direct it firstly to Penny, and then open it to others to also speak to, is what are your thoughts of health professional conferences using sponsorship from companies that market infant formula, but come to these conferences promoting another product? Perrigo is a major sponsor of Australian College of Midwives events, the largest maker of infant formula worldwide, but they also make other products. So that's their excuse for coming along. Penny, what are your thoughts on this?
Yeah, thank you, Deepa, and thanks to, I think it was Linda, for the question. Good to see, I think, a fellow midwife here, and possibly you're a member of Australian College of Midwives, as I am. And this is, I mean, a really good point that, you know, it's so covert. I wouldn't have known, you know, you just sometimes you can't make those connections, but raising awareness as you've done, and I think within our college, I mean, we just maybe need to get together like as a working group to address, you know, the covert influence. I mean, I think the other point that comes out here is that the education is so needed, but it's so poorly resourced that, you know, like the college, for example, has to resort to accepting sponsorship wherever they can, really, even if it does. I mean, it's obviously a serious conflict of interest. So, you know, if education was properly resourced, you know, and rolled out, then this wouldn't be the case. But yeah, I'm interested to hear other people's thoughts. And yeah, I've experienced this issue, you know, myself, where keynote speakers have withdrawn from education events because they've suddenly became aware of, you know, this conflict that we're presented with. So good on you for raising that awareness. And yeah, someone else wants to add, I think. So thanks.
Julie?
Yes, I reinforce what Penny has just said, and also to raise the broader context for this, which is that the pressure is on individual facilities and individual organisations to fund professional development training on breastfeeding. And the reason for that is because it's terribly neglected in medical training and in, you know, the training of health workers. And one of the key action areas, the priority action areas actually of the National Breastfeeding Strategy in Australia, is to redress that situation so that the cost of having skilled, qualified, knowledgeable health workers, medical workers, is borne at a higher level in society, at the system level, rather than being imposed on either the individual health workers themselves, who have to pay for their own PD in breastfeeding if they're motivated, or their facility, if that chooses to be a 10 steps or breastfeeding friendly facility. That we need to move this to the system level. But as we've discussed in paper 3 today, there is some very high level and sophisticated and subtle lobbying that goes on that makes sure that strategies like the National Breastfeeding Strategy, which prioritise supposedly these sort of big picture system level issues, there's a good reason why that funding's not forthcoming. And I'm really pleased to be part of a team that's exposed the power systems behind all that.
Thank you, Julie. And over to you, Phil, to add to that. Oh, you're still on mute, Phil.
Sorry about the technical issues today. So I just want to add to that, the influence of the formula industry with health professional associations, education and training is really extensive in all countries. We report this in the series as well as in the accompanying papers. One of the things we also found was the huge deficit in the training and education of health professionals on infant and young child feeding, especially on the support, the protection, promotion and support of breastfeeding. That is a huge gap that needs to be addressed. And I think that is one really key thing that health professional associations can do. The other thing is there are just conflicts of interest all through health professional associations worldwide. And we are now seeing leadership from some of those professional associations to address these conflicts by adopting policies on how they engage with the formula industry, the receiving of sponsorship and so on. So I would just say that is a blanket recommendation for anyone joining us from professional associations today, is to take the lead on this and advocate for more training, more education, and also to end these conflicts in your professional associations for those who haven't done so already. Thanks.
Thank you, Phil. I've got a question for Catherine. So how can we regulate extensively digital marketing in this space? This does seem really challenging.
I mean, I think it's a really big question at the moment because it is, well, I think we're led to believe that it's harder than what it is. So, you know, industry certainly tells us that it's really hard to regulate digital marketing. But when we start talking to, you know, people actually working in this space, who are the people on the ground doing the marketing for digital, you know, platforms, they tell us it's actually a lot easier than what we're led to believe. But there are lots of things we need to think about to iron out. I think one of the biggest points in regulating digital marketing is how we separate point of sale retail, because often, you know, with those buy now buttons, you know, in the food space, more than 70% of ads actually have a buy now button now, and they would be excluded from some of the regulations that are in place around digital marketing of unhealthy foods and non-alcoholic beverages. So I think, you know, it's really defining some of those policy parameters a lot clearer, and we need to do a bit more work. And then making this information available for countries to provide guidance. It's such a complex area, and I think, you know, countries need a lot more information around how, you know, what does a legal response to regulating digital marketing look like? What are the technical parameters that need to be considered? And then once you know those technical parameters, what are the legal considerations for making sure that you include those technical parameters in the legislative response as well? And I think there is some work with the WHO that's going on there, particularly in the area of breast milk substitutes or, you know, commercial milk formula. And also, you know, I think it's a hot area at the moment. So I'm hoping in the next couple of years we'll have a lot more work in this area and get some examples up worldwide that can, you know, set the example for other countries to follow.
Thank you, Catherine. And Francis, what do you think international agencies and organisations like UNICEF can be doing or would like to do in this space, as all the challenges that have been brought up seem very complex, and some of those are affecting countries in the Pacific more so than others. What do you think is the role of agencies like UNICEF in this space?
Yeah, thank you. So I think one of the entry points for the UN agencies is really engaging with the communities and working well with the communities and advocating that. And we've seen that work with, you know, like our immunization program, where we try to increase the rates of immunization. And like I was mentioning earlier, is actually leveraging on this existing programs that have worked well within the health sector, and using that opportunity to advocate for breastfeeding when you have contacts with mothers and caregivers. So engaging with communities is really a space that we could work into, and also supporting countries with the policies, you know, having policies in place and regulatory measures to support and protect breastfeeding in the countries. These are two really good entry points. And like, you know, we mentioned earlier, building the capacity of healthcare workers, because breastfeeding is really not, it has a really strong practical component to it, where, you know, you really need to have the skill to be able to help mothers breastfeed. Health workers need to have that skill, apart from the knowledge and the know-how, but the skill to support and help in attachment and breastfeeding and so forth. So these are really important entry points where we really build the capacity of health workers in this space.
Thank you, Frances. And I'll go to Julie, who has something to add.
Yes, thanks, Frances. The comment about assistance for policymakers and policy formation, I think, is a really pertinent one. And one of the features of the Lancet series is the call for an international treaty in this space. And that could include, and being modelled, for example, on the Global Framework Convention on Tobacco Control, includes requiring declaration of lobbying activities of companies, or in some cases, you know, and banning it, just banning it. It should, you know, Mother's Milk Incorporated is entitled to be up there lobbying our parliamentary decision makers, not the industry.
Thanks, Julie. And for Libby, how do you see the recommendations of the Lancet series as helping to advance food security for infants and young children?
I think the Lancet series can be tapped into in two really important ways. I sort of mentioned retaining industry power through reframing and presenting breastfeeding as the solution to the problem of vulnerability rather than it being the problem. And I think that crises and inequities blow apart this choice that's so strong in marketing and in the neoliberal sort of politico-economic constructs around infant feeding that makes health professionals so hesitant. I think the second contribution that first food security make is to this fifth recommendation, which was to increase public finance and alignment of public and private interests. And it's just not a nasty form of political opportunism. I think it really engages with the capacity of institutions to shift in the aftermath of a crisis, given the political and economic stresses of these crises and their increasing frequency. You know, insurance companies are really starting to show the strain of just in Australia, for example, of climate change disasters. So, and as shown very poignantly in the pandemic, system failures to support breastfeed and protect it become really obvious in a crisis and start to shift attention back up to those structural causes and create political windows for policy action. To seize. And that takes some strategic work by coalitions of workers, and that's the sixth recommendation is about mobilising coalitions. And I think first food security doesn't abandon health as a framework, but it should broaden the framework to engage a wider group of advocates, nationally and regionally and internationally. You know, for example, firefighters, defence forces and emergency staff are typically removed from that sort of women's business of feeding. But when they're in the command and control structure, and work like Carleen Gribble and others in the Australian Breastfeeding Association are showing how breastfeeding can be protected and supported and promoted during those crisis moments. But very importantly, it's about building awareness and then building, I think, things like and breastfeeding included on an index of community and national resilience to climate change. Right? And importantly too, recognising women's care work as critical work just becomes much more obvious in a crisis, and helps provide incentives to collect data, really meaningful data on child feeding at a granular level. So I think the food security framework really offers potential to progress those really important coalitions.
Thank you so much, Louis. So while we had a lot of questions that we wanted to answer, we are at 2:30. So I'm going to throw now to Phil to wrap up and close the session.
Thanks so much, Deepa. And thank you to the panelists, the speakers today, and most of all to everyone here who joined. We had 350 people register. I think in the end we had about 150 people on here at one point. I would also like to encourage you to access the Lancet 2023 Breastfeeding Series, to go to the website, to read the papers. There's also an accompanying editorial, there's a commentary, and really dive deep into the findings, into the messages, and do what you can to harness these messages in your work, whether you're a policymaker, a health professional, a civil society advocate, or a researcher, or most importantly, if you're a mum, a dad, and you're concerned about these issues for you and your family or your community, please make the most of this series. We couldn't cover everything in the series, and there are lots of really important topics that have been raised in the questions today on social media, on Twitter. And to those people who have raised these questions, we see them, we think they're important, and we will continue doing this research and helping to answer those really crucial questions that you yourselves are helping to ask. Finally, I'd like to acknowledge my wonderful colleague, Julie Smith, who was just a fantastic collaborator on this series, who has done so much for breastfeeding women, for this issue internationally. So my huge thanks, Julie, for the wonderful work that you've done. You really do deserve a huge medal. And finally, a call to action. Collectively, we have immense power. The final recommendation in the series was exactly this. We need to see this as an issue of power, of a matter of political economy, and the antidote or solution to that is to uppower what we have. And those are our ideas, the evidence that we have and the evidence that we can generate, but also our ability to collectively mobilize. And we've seen this internationally, especially from mothers and women themselves, protesting outside the Supreme Court in the Philippines, mass breastfeeding events, making submissions to Parliament, connecting with our politicians, but also joining women's groups around the world. And the power of mothers themselves to generate change is incredible. And that, I think, is the work we have ahead of us, to think about this more. How can we collectively mobilize, as Libby said, broaden these coalitions and really take on this challenge and take it to a whole nother level internationally. Finally, we have a video of the key messages from the Lancet Series authors. By no means you feel obligated to stick around and watch the messages. They're only there if you'd like to watch them, and I will play that video for you all now. So thank you again, and thank you, Deepa, for your wonderful moderation. Bye.
As they try to provide their young children with the best start to life. Paper 1 reports how normal infant behaviours develop over the early months and how they influence feeding practices. Paper 2 documents how the formula industry reframes these same normal behaviours and leverages parents' anxieties and aspirations to promote their products. But marketing is much more extensive and sophisticated and powerful than just adverts or the messages on formula packaging. Papers 2 and 3 show how health professionals, politicians, international bodies and agencies are all targets through lobby and subtle influence. We in public health and society in general have never fully appreciated how all these come together as a commercial system of influence that undermines not only breastfeeding, but also child and maternal health and human rights.
It's important that families have truthful and impartial information to help inform the feeding choices that they make for their children's well-being. This series sheds light on how this is not always the case and makes useful recommendations on how we can begin to change this. As a mother and as a public health professional, it's exciting to see this kind of empowering information enter the public domain.
The Lancet 2023 Breastfeeding Series highlights the latest science on the dynamic and interactive nature of breastfeeding. Breastfeeding is so much more than just providing nutrition for babies. It has important hormones affecting bonding and stress, immunity factors actively fighting off diseases, microbiota protecting the gut, and skin-to-skin contact that supports temperature control. While breastfeeding was once universal in humans, various economic, political, and social factors have created numerous challenges to breastfeeding. These challenges have driven down rates of initiation and continuation throughout the world. This Lancet series draws particular attention to the marketing that it creates an artificial demand for commercial milk formula and how that marketing impacts families, healthcare providers, employers, and politicians. To protect the health of mothers and children, we must address the societal barriers to breastfeeding.
To my knowledge, the Lancet series is the first to foreground maternity rights along with the harmful effects of private corporate profit seeking in the area of breastfeeding. It does this by reaffirming breastfeeding as part of women's care work and thus central to infant and child care. Now, while care work largely and indeed overwhelmingly done by women across the world is increasingly recognized, it continues to be poorly resourced, whether in terms of financing or in terms of women's labor and opportunity costs. This is true in spades for breastfeeding, and this Lancet series brings out the challenges very well. But it also shows that, in fact, if political and will were there, it is not impossible. In fact, it is very possible to adequately finance breastfeeding, for instance, through effective corporate taxation. This resourcing problem faced by women who breastfeed is particularly true in low and middle income countries, but it's far from sufficient. The resources are far from sufficient in high income countries either. Breastfeeding has to be recognized as a public good, and this series by the Lancet goes a good way towards making that possible.
It is staggering that millions of infants and young children, instead of being fully and properly breastfed, are given a costly and more environmentally damaging artificial product that's inferior in quality and which increases the risk of harm and even mortality. This Lancet series includes a comprehensive examination of the underlying social, political, ideological and economic reasons for this unacceptable situation, including a look at the hugely problematic imbalance of power between profit-maximizing financial and corporate actors relative to those who have a duty to promote and protect the health and rights of children and mothers. As such, the series speaks not just about the barriers to breastfeeding, but also about wider cross-cutting pathologies in our political and economic systems.
This series picks up where the 2016 Lancet Breastfeeding series left off, addressing several important topics that have been, until recently, overlooked or ignored. For example, the papers describe the commercial milk formula marketing playbook and several of the strategies industry uses to present formula as a solution to common parenting challenges. Myths perpetuated by industry's advertisements that formula will make kids smarter, sleep better, or be less fussy are discussed and dispelled. I joined this effort because I believe it is important for the public and policymakers alike to understand the commercial determinants of infant and young child feeding, the systemic barriers to breastfeeding, and how society as a whole can support women and families in a way that is free from commercial influence.
This series calls for the prevention of the unnecessary introduction of infant formula soon after birth, which oftentimes happens in response to the misinterpretation of normal baby behavior, such as crying, as signaling insufficient milk production. The early introduction of formula is a major risk factor for stopping breastfeeding prematurely. For this reason, the series also calls for strengthening the training of healthcare providers on understanding and managing baby behaviors without undermining breastfeeding. Another key contribution from the series is that it provides the evidence behind the call for well-coordinated, multi-sectoral breastfeeding programs that protect the immense public health value of breastfeeding while respecting the right that women have to breastfeed for as long as they and their babies desire, with support from the whole of society.
Speaking as a feminist economist, the power of this series is in linking biology, marketing, and political economy to show the big picture about what makes breastfeeding difficult for women. Women are central to the nutrition, health, and survival of infants and young children. Breastfeeding is a core human rights issue and important for women's reproductive health. Yet our political, economic, and health systems ignore, devalue, overburden, and mistreat mothers, turning breastfeeding into a heroic sacrificial act. Dependence on commercial milk formula has large costs to the planet and to people. We call for governments to do better. This includes counting women's unpaid work, budgeting for breastfeeding, and prioritising respectful maternity care.
I had the honor of being one of the leaders of the Lancet first breastfeeding series in 2016 and to witness its huge impact. The current series expands upon that earlier work by documenting how the harmful promotion of infant formula is affecting breastfeeding practices in low and middle income countries. We hope that our findings will motivate international agencies, national governments, and civil society to strengthen regulations on marketing practices that threaten the good health and nutrition of children worldwide.
I became involved in this series because of my work on the importance of breastfeeding in human evolution and culture, and because of my appreciation for the tremendous impact of breastfeeding on health across the life course for entire families and communities. Few people are aware how much formula companies interfere with and undermine breastfeeding. For me, the key message of this series is that we have a social obligation to enact policies that stop this interfering and that protect, promote, and support breastfeeding so that all families and all communities can realize these tremendous benefits. This is a key way that we can improve and alleviate health inequities throughout the globe.
One of the key messages of the series that resonates with me is that the marketing of commercial milk formula is a system that is more complex and more powerful than we ever imagined. The system was designed and has been honed over decades to capture the most trusted institutions and individuals who influence decisions on infant and young child feeding, especially breastfeeding. The system methodically preys on the hopes, fears, and aspirations of parents and on their desire for reliable information, all for profit and at the expense of the health and rights of parents and children.
I joined the series because I conducted the multi-country study looking at the influence of marketing across countries and realized the size, scale, and sophistication of this marketing machine. I heard women discuss how they'd been told that formula would make their child taller, more intelligent, or would sleep better. I heard them talk about how premium products cost all of their wages, but they believed they'd give them better outcomes. I heard health professionals discuss how they're constantly targeted by industry reps with financial and other incentives to sell their products. And I heard marketing executives discuss how they pose as mothers online in order to coerce people into buying their products. This marketing machine puts profits over people, and as ultimately all of this is at the expense of the child. And I believe that this marketing really needs to be curtailed, if not stopped.
I would like to highlight two key messages of the 2023 Lancet Series on breastfeeding. The first one is how mothers and baby attributes interact with key structural breastfeeding barriers and how these interactions drive infant feeding decisions and practices. Particularly, there are some common infant behaviors, such as persistent crying, fussiness, speeding up, and short night sleep, that often are interpreted as signs of feeding problems. And the second one is the evidence supporting the importance of multi-level and multi-component intervention to address breastfeeding protection, promotion, and support. These interventions will contribute to generate an enabling environment for women to breastfeed their children optimally as long as they or their babies desire.
There are a number of exciting new developments in this new series on breastfeeding. There's the update on the scientific evidence of the benefits of human breast milk and human breastfeeding for infant development. There's also data which shows that prelacteal feeds, or giving water, formula milk, in the first few days of life can inhibit the establishment of exclusive breastfeeding. And very importantly, it shows that the early adaptations that infants are making to the outside world, the fact that they need to feed frequently, that they are irritable, that they have short sleep, wake cycles, can lead parents to feel very anxious and to wonder what they can do to ensure that their care for their baby is the optimum care they can give. And it especially precipitates an insecurity about the quality and quantity of a woman's milk. Now, formula milk companies capitalize and exploit on this parental insecurity by, number one, pathologizing these absolutely ordinary infant behaviors, and two, by offering unsubstantiated solutions to these in the form of formula milks, different varieties of formula milks, and especially special milks that they claim will make babies sleep longer, cry less, and so on, which, as I say, are completely unsubstantiated.
There are three main messages that really resonate for me in this series. First, the industry has managed to grow its sales year on year on year through ever more aggressive modes of marketing and by finding new ways to market around the regulations. We must end exploitative marketing. Second, as the industry has grown, it has invested huge resources into gaining political influence in many countries and internationally to block any new regulation. If we are to advance breastfeeding, we must end this political influence. Third, breastfeeding is work. It takes time, effort, and skill, and it has immense economic value. Yet breastfeeding women aren't being recognized as contributing to the economy, whereas milk formula is. This perverse economic paradigm is deeply unfair and must be transformed.
In the first paper of the Lancet Breastfeeding series, we're showing that over the past 2 decades, early initiation of breastfeeding almost doubled, and that exclusive breastfeeding also had a steady increase. In spite of these improvements, much more needs to be done because few countries are on track to meet the World Health Assembly target on exclusive breastfeeding. We are also showing that nearly half of the women globally self-report insufficient milk as a primary reason to introduce commercial milk formula products and stop breastfeeding. We know that one of the reasons is that parents often misinterpret unsettled baby behaviors as a sign of milk insufficiency and they want to introduce something else. This misconception is often reinforced by the marketing of infant formula. What we're saying is that these baby behaviors are generally normal, and with adequate lactation, counseling, and support, self-reported insufficient milk can be addressed. Lastly, breastfeeding is not the sole responsibility of women. Really, a collective societal approach is required to support women to breastfeed as long as they want to.
I was thrilled really to be invited to make a small contribution to an area that interests me greatly, which is to critically examine how powerful corporations, in this case those that manufacture and market commercial milk formula, impact on health, rights and well-being.
I'm happy to be part of the Lancet 2023 Breastfeeding Series because there is an impressive and growing body of scientific evidence showing that breastfeeding is far superior to formula feeding. Our understanding of the complex biological system shared by the breastfeeding mother and her infant is rapidly growing. New components of breast milk are still being identified, and these components interact in ways we are just beginning to understand. These new developments clearly demonstrate that, try as they might, formula companies cannot replicate the dynamic, live, and personalized nutrition, immunity, and health benefits provided by breastfeeding.
The infant formula business is a classic case of market failure. Every parent wants the best for their child, but each year, over 1.5 million mothers and fathers are tricked by industry marketing into making catastrophically bad consumption decisions on the part of their babies. The world has spent most of the last 50 years trying to bring this gross mis-selling to an end, but the industry has used every ruse and deception to evade regulation. Babies, parents and future generations are paying a terrible price for their greed and dishonesty. A framework convention is the best way to rectify this calamitous state of affairs.
As an economist, I was very happy to participate in the Lancet series on breastfeeding to help draw those connections, to help people see the connections between our economic policies and the environment, the challenges that parents face when they're trying to make decisions about infant and young child nutrition.
Over the years, the baby food industry has grown significantly through rapid market expansion and product diversification. Such economic power, facilitated by the deployment of aggressive marketing strategies, has translated into increased political power, which the industry has used to oppose legitimate regulation to the detriment of public health, sustainable development, and human rights. In this series, we expose these strategies and argue that states must effectively regulate them to comply with their legally binding obligations to respect, protect, and fulfill human rights, and particularly the right to health and the right to food. It is only then that women will be in a position to genuinely choose how they feed their young children.
I think the main reason to join this outstanding team of experts in producing such compelling evidence about breastfeeding is that I truly believe that breastfeeding goes beyond than only nursing the infant. It also expresses the love between mother and child, which also can be expanded to the whole family. It's time for the whole society to be more proactive in protecting, promoting, and supporting breastfeeding through empirical evidence of the main drivers that influence breastfeeding across the globe.